What the plan is here, if we get 10 of us, and you'll just have to forgive me, if we get 10 senators here, we've got some leases we need to get done. So if you're talking, I'm going to probably gavel you down. You can take up, we'll do the business meeting, we'll get it done. So, because these leases are very, very important, and this is the way it has to be done. That being said, I want to welcome everybody to today's hearing on the President's fiscal year 2025 budget for the Department of Veterans Affairs. Before we begin, that's where I just said this. All right, we are joined by the Honorable VA Secretary Dennis McDonough and the Veteran Service Organization, authors of the independent budget. This year's request is $370 billion, represents a 10% increase over FY24. I look forward to discussing how this budget proposal will ensure we're meeting our veterans' needs now and into the future. It is undeniably a historic time for the VA and for veterans' health care and benefits. With the PACT Act delivering the largest expansion of VA health care and benefits ever, and more folks coming into the system, we have to ensure that the VA can deliver for those veterans timely and in a way that they have earned. I know that is your primary focus, Mr. Secretary. VA's recent hiring surge allowed the department to deliver an all-time record number of health care appointments due in part to the PACT Act. VA needs to continue to build on this momentum and continue to hire, retain quality personnel, especially in critical specialties, mental health, and especially in rural America. When veterans can't be seen in a timely manner or they have to drive too far for services, they need to be connected up with community care, and quickly. In Montana, community care has played a key role in bolstering veterans' access to care. Nationwide, in FY23, nearly 40% of VA's total care workload was delivered in the community. But study after study shows that VA health care is as good or better to what the folks are getting in the private sector. And veterans almost always like their VA care more than non-veteran counterparts like in the private sector. So the VA needs to maintain its capacity to deliver health care to veterans with an eye on safeguarding its role in medical education, research, and acting as the nation's backstop in emergencies. And it needs to right-size what health care it delivers and the health care that it buys. In addition to investments in staffing, VA and Congress must continue to push for more stable funding for improvements to infrastructure. At the moment, we're barely scratching the surface. Without safe, modern buildings and equipment, VA's direct care system will struggle to meet the ever-evolving needs of the veteran. On the benefits side of the ledger, VA needs to continue to deliver veterans quality claims decisions in a timely manner. It must also ensure the Board of Veterans Appeals is adequately funded to handle an increased workload. Passage of the PACT Act makes that more important as ever. Mr. Secretary, I want to thank you for being here today. I appreciate your continued leadership and dedication to our nation's veterans. I also want to welcome our second panel of advocates to discuss these challenges from a veteran's perspective on the ground and how this budget applies to them. With that, I'm going to turn it over to Senator Moran for any opening comments he would like to make.
Chairman, thank you very much, and welcome to Secretary McDonough and our VSO witnesses. I'm anxious to discuss the VA's budget request and what resources the VA needs to deliver care and benefits to our nation's veterans. Congress and this committee have a long track record of working in a bipartisan manner to provide the VA with the resources it requires. This committee has worked to address major challenges veterans face, including streamlining access to disability compensation and providing health care for veterans exposed to toxic substances during their military service. It is up to the VA workforce and leadership to faithfully execute the legislation passed by Congress and deliver the care and benefits our veterans rely on. I know many VA employees in Kansas and across the country who selflessly serve our nation's veterans. However, I hear from VA employees that despite record hiring and retention last year, the VA still faces staffing shortages which are straining the workforce and increasing wait times for veterans. The VA leaders have repeatedly said there's not a hiring freeze, but that is not the message that the VA facilities across the country have received. In contrast, the VA has noted that community care costs are rising too rapidly and VA facilities must recapture care from the community. The VA is also expecting to reduce 10,000 employees in the direct care system, yet VA's system for assessing medical center performance for veterans shows, quote, meaningful decline in access across the VHA. Mr. Secretary, I'd highlight a letter that I think the answer, we were requesting a due date today from Senator Tester and I on this topic of workforce and the 10,000. Mr. Secretary, I hope this afternoon we can have a frank discussion on these conflicting messages. Veterans deserve the right to decide when and where and how they seek the care they need. I remain committed to making certain they continue to have the opportunity to make informed choices about their own health care. VA has a responsibility to consistently provide veterans with timely information, approvals, and improve veterans' experiences when seeking care. I want to highlight this point, and the chairman mentioned this topic in his opening statement, but I want to highlight again, non-VA emergency care costs are the biggest driver of increased community cost care. Yet the department has not articulated a strategy to address the emergency care spending. Additionally, I'd like to know the impact of VA's decision to delay preventive care and cancel appointments during the pandemic and how that may now be impacting the current increased demand for emergency care. I look forward to our discussion today, and I thank you, Mr. Chairman. I thank you, Mr. Secretary.
Thank you, Senator Moran. I want to welcome Secretary Dennis McDonough, Secretary of the VA. The floor is yours to talk about the FY25 budget.
Thank you, Mr. Chairman, Ranking Member Moran, distinguished members of the committee. Thanks for the opportunity to testify. Maureen Ropsch is an Air Force and Coast Guard vet who comes from a long line of military service. Her family members served in Vietnam, World War II, and the Korean War. Maureen qualifies for community care but chooses to get her care at the Manchester VA Medical Center. After a recent routine mammogram, Maureen was diagnosed with breast cancer. She says her VA nurse navigator, Kelly Hunt, was by her side every step of the way, making sure that her surgery and radiation happened right away. Today, thankfully, Maureen's cancer-free and receiving treatment to safeguard against recurrence. Maureen says, "It's such a comfort knowing I have this team on my side." She goes on to say, "The difference I feel when I get care at VA is significant. I feel like I'm home. The providers take that extra time to understand my complex health history. I feel like they see me." We owe vets like Maureen and all vets our very best. We're fighting like hell to give them exactly that. We're delivering more care, more benefits to more vets than at any other time in our nation's history. Since March 5th, expansion of health care eligibility to all veterans with toxic exposures, we've enrolled more than 12,500 veterans under that PACT Act authority alone. That's just since March 5th. And over the course of the last year, we enrolled over 400,000 new vets, 30% more than the previous year, and an increase in all 50 states. 6.5 million vet patients had over 118 million clinical visits, 47 million in the community, 42 million in person at VA, and 29 million via telehealth. The last data point bears repeating. Millions of vets use VA telehealth. Now, on to benefits. We decided over 1.9 million claims, shattering the previous year's record by 16%. We've all heard justifiable frustration with CMP exams. Yet in the last year, we processed 2.4 million CMP exams, a record by nearly 30%, and took an average of just 31 days to complete them. In total, we've delivered $163 million in earned benefits, $1 billion in earned benefits to over 6 million veterans and survivors, another record. And the PACT Act has opened the door to millions of toxic exposed veterans and their survivors, bringing generations of new vets to VA healthcare and expanding benefits for many more. The PACT Act is also delivering additional benefits for veterans to the GI Bill, VR&E, home ownership, survivors' pensions, and so much more. Benefits that not only improve the veterans' lives, but strengthen the American economy. We still have a lot of work to do, and the President's budget fully funds VA's ability to do that. That work is also about preventing veteran suicide, ending veteran homelessness, supporting health care for women vets, modernizing our IT systems, processing benefits, and honoring vets with eternal resting places. No single investment is more critical to the veterans who we serve and VA's future than the people we hire and retain. Teammates like Tarina Brufton, a housekeeping supervisor at the Cincinnati VA Medical Center. Tarina's husband is a vet. She says she goes to work each day striving to provide the kind of welcoming environment she'd want for him at VA. That's the kind of deep devotion that characterizes VA's people. And Tarina says she's grateful for the critical skills incentive that she received, a CSI. Her daughter's prescription cost her $700 a month, and the CSI has allowed Tarina to focus on her work as a supervisor without the financial stress of wondering whether she'll be able to afford her daughter's life-saving medication. Now, today marks the first day of Nurses Month, where we honor VA's 122,000 nurses. Let me repeat, 122,000 nurses, the largest nursing workforce in the country. That's up about 14,000 nurses since December 2021. Now, that's one reason why we feel quite comfortable with the staffing numbers outlined in this budget. The work of caring for brave men and women who fight our wars and their families, survivors, and caregivers. Do you have 10, Mr. Chairman? If you've got 10, I'm happy to suspend.
We don't. We're looking for them, though. We're
Is in
hunting
full
them.
swing and continues to grow. The Mission Act, the COVID pandemic, and the PACT Act, all over just the past 6 years, have changed the American healthcare landscape and the statutory basis for the work we do at VA. Any one of those on its own would lead to monumental change for VA. But together, they have changed the way we do business, creating some challenges, but mostly opportunities for veterans and VA. And right now, we're at a critical moment for shaping and securing the future of veteran health care. So we'll work reliably to offer care options to every veteran, VA care options to every veteran, even vets who qualify for community care under the Mission Act. We want to bring as many vets as possible into our care because study after study shows that vets do better when they come to get their care with us. Whether in person via telehealth in our community living centers, mobile medical units, or elsewhere, vets can access VA at almost every turn. What we do this year and over the next several years, building on the generosity, bipartisan generosity of Congress, and the innovative hard work of VA's workforce, the best in the federal government, will determine what vets can expect from VA now and how we'll deliver that high standard of care well into the future. So, we look forward to collaborating even more effectively with you to build on what's working and being candid and addressing what's not. Thank you. I look very much forward to your questions.
We appreciate your opening statement. I'm going to turn now to the chairman of the Senate Appropriations Committee, Patty Murray, for her questions.
Well, thank you very much, Mr. Chairman, and welcome, Mr. Secretary.
Thank you,
Good to see you. Thank you for all you do for our nation's veterans. We appreciate it. I want to ask you, as you're probably not going to be surprised about the EHR system. It has 2 facilities in Washington State, as
Yes.
you know, and I am still hearing from veterans and providers about their struggles with that system and how it has undermined their health care. We're still hearing about some outages and referrals or notes that aren't being recorded, canceled procedures. So it's still a work in progress that we've got to focus on. And I know we're in a reset right now. I know you're taking that seriously and trying to get this corrected. You are asking for $894 million for the EHR program in FY25. Can you talk to us about how VA will use those funds to make safety improvements and IT upgrades?
Yeah. Well, thank you very much, and I'm not surprised by the question, Madam Chair. Our Deputy Secretary just spent yesterday and the day before in Spokane and Walla Walla. She's now in Oregon, and she'll be in Columbus tomorrow at the 5 sites. What we've said is that we've tried to right-size our eyes and our stomach on this budget, so that what we're asking for is a significant drawback from what we would have anticipated under the original 10-year plan. So what we've also said that we won't leave reset until we're ready, but we don't intend to stay in reset forever. So I hope that by the end of this fiscal year, we'll be in a position to be out of reset. But that'll be determined by the facts on the ground. The DepSec's visit is a big part of that right now, as is, of course, the experience in your 2 facilities. Now, since the last time we talked, where we're not in reset is in Lovell, in the federal healthcare system, healthcare center in Chicago. That's gone better than expected, based principally on the learnings from the 5 live sites. They've gone back to much higher productivity than we had anticipated. So the investments we anticipate in '25 are based on both the experience of the 5 sites and the experience in Lovell. That will get us moving out on a more realistic timeline to new sites based on that facility. Now, we've also forward deployed much of the funding in those for FY25 in the next level of facilities, getting them ready for pre-investment for some of the deployments. So we anticipate, as I say, by the end of this year, making that this fiscal year, making that decision and moving out smartly with that more reduced investment in '25.
Okay, thank you very much. Obviously, we're going to continue to follow that.
Yes.
I fully funded the President's $23 million request in the FY24 bill to expand VA's child care pilot program that we established back in 2010. It's really important to me that veterans don't forego their health care because they don't have any child care. And I have to say, I am disappointed that VA is not making progress faster on this. According to a recent study published by NIH, a staggering 58% of respondents reported missing or canceling VA health care appointments due to child care challenges. Last year at this hearing on your '24 budget request, you told me you would get the regulations moving on the expansion. We're sitting here today. We've been told it may take another year now for them to be finalized. When are we going to see movement on that initiative?
Well, I appreciate the question very much. We have a two-pronged strategy, as we've discussed. One is to reimburse veterans for their care that they get somewhere else, and then consistent with your authorization to make sure that we have on-site child care where possible. We think the 2 places most likely for that are Fresno and Shreveport, and we're working with those 2 facilities to invest in those opportunities. The regulations are in process, and we're hoping to have those regulations done this year.
Okay,
But
the chairman's going to...
Hold that thought.
Okay.
Patty still gets a minute. We've got 10 folks here. I want to recess, call executive session. We're to consider a resolution to improve access to care for veterans in South Carolina, Texas, Florida, Pennsylvania, New Jersey, and Delaware by approving 10 VA major medical leases. These leases are from the FY 2024 budget submission information that was distributed to senators back in December of last year. Again, last week it was distributed and was also briefed to your staffs. Hopefully you're familiar with it. Before we move to vote on the resolution on today's agenda, any comments or debates, Senator Manchin?
Yes. As you know, I think I have a concern. And the concern is that we're paying for everything. And whoever owns these facilities are reaping the rewards. I understand that we're going to increase from 31,000 to 151,000 square feet on a VA, an average of 64.2 million. And we're making an infrastructure, the average annual rent will increase from 1.1 million to 7.2 million, and we're the ones spending the $64 million up front to enhance these properties and paying someone that much more. It makes no sense to me. None of us would do a business deal like this. None of us. But here we are. I guess it's print money is no problem, right?
Yeah, no, it's always a problem, and if I just might.
Someone can clarify this
I'll just,
for me.
well, first of all, and you correct me if I'm wrong, Mr. Secretary, we're talking about leases that are 10 or 15 years old that we're replacing, okay? That's number one. Number two, the square footage, I believe, is matched to the demand of the veterans. We've been at war. I don't need to go over that. But the fact is we have been, and the VA has been doing what I think is a good job, and they got to do more on this, by the way, of bringing in veterans who are literally not in the system, who have got problems. So the demand is growing, plus the PACT Act. The second thing I would say,
the average increase is 5 times greater than what the size is right now.
The
31,000 is about the average of the 10. It's
Yeah.
going to 151,000 square feet.
I've got you, but the fact is that the demand is there. I mean, we're doing medical stuff, we're doing mental health stuff, we're doing all sorts of specialty cares that are there. The only thing I would say is this: the VA, in what month was it, put out 31 leases for bid.
Yep. December.
And you may or may not know this, those bids came back, 10 of them were acceptable, they were within the rate, and and the secretary is gonna hopefully approve those. There were 4 or 5 that were within margin, so they can negotiate. 17 about were not, and the secretary said, look, man, we're gonna go back and sharpen your pencil, or this ain't gonna happen. And so I think your message is being heard, Joe.
Okay, the only thing, Sanders, what I'm saying is this. I'm okay with the expansion. We want to give the service. If we're going 5-time increase, 5X increase, that's fine. We have to justify the services. It doesn't make sense to me that I own the building. You're going to renovate my building completely for me on a 10-year lease. Most is amortized 20 to 30 years, but 10-year lease, you're going to do all of it and still pay me the increases of the additional footage. I understand. That's one heck of a deal for me as a landlord. One heck of a deal.
Yeah.
Now, I'd have to get some discount. I don't know what the square footage rates are, things of this sort, but there has to be something that we can tell the taxpayers that we got a little better deal. Right now, we're paying the full freight.
Gotcha. Folks, these do me no good. I should have had these a long time ago. All I'm gonna tell you, Joe, is.
I know, you all have to
These
vote.
been
I'm gonna vote
approved.
against it because I think it's a bad
That's fine.
deal.
I'm just saying, this has been approved through the appropriations process. I do not want to be in a position as the chairman of this committee running the VA. That's McDonough's job.
No, I trust,
When they
I
talk
trust the
about, when
secretary
they
of
talk
my
about
life.
square footage, they've got Al Nahal at the table, and they've got other folks at the table.
Well, he's
that are
got
talking
somebody
about
doing, I don't know who's, I mean, raise
So-
their hand, who's in charge of finances there, but I can tell you, this is a bad deal. It's a good deal for me. If I'm the landlord, you did a heck of a deal for me.
it. Sure, absolutely. Go ahead. Would you?
I think it's a fair question. We're building the facilities where the vets are. That's the whole strategy, which is we're trying to skate to the puck. We're trying to make sure that, like the rest of American healthcare, we're building based on outpatient structures rather than the old, big hospitals. We're trying to build these in communities where the vets are. 1. 2, the alternative for us is building brand new in many of these markets, which is even more expensive. And that's a function of interest rates where they are now and supply costs where they are now. And so what we're doing, healthcare inflation over the course of the last 10 years is obviously a major challenge for us. But we want to make sure that we're building where the vets are, and we're finding the most cost-effective way to do that. We think that these leases are that.
Okay, well, let me just, if I can just say this. The average rent is going from 1.1 million to 7.2 million. That's the average. The average size goes from 31,000 square feet to 151. I don't know how that is, and every area is a little bit different on rent and all that.
Right.
But on top of that, then if you come to me and you'll give me a 10-year lease or a 30-year lease or whatever I can get from the federal government, and you usually give me a spec of what you want me to provide for you, and then my rent's adjusted to the spec and this and that. But for you to come in and pay the full load, and I give you the space, but you're paying the full conversion, and I get to own it in 10 years, I might say, okay, I can rent this to somebody more. The taxpayers are paying the full load on this, is the way it looks to me. Could be wrong, I don't know. Somebody wants to explain it differently, but it looks like that it's not a good deal.
Look,
It is what it is.
What-
You guys got to vote, I understand.
I'm gonna let Tellis say something. Senator Tellis, that is.
The other thing I was gonna say is, I just take that Jacksonville, North Carolina's not on the list. I think overall, we've got to start using these sort of vehicles, or we've already got a backlog in terms of facilities requirements. It may not be perfect, but it beats the heck out of what it would take to take something out of the ground in Jacksonville, North Carolina. I know we were in the mix. I've got some questions, but I'm gonna be voting aye.
Okay. If there's no more debate, I'd like to invite a motion for a roll call vote on the pending business.
Mr. Chairman, I move the Committee on Veterans Affairs hold a roll call vote to favorably report the Major Medical Lease Committee resolution.
The clerk want to call the roll?
Mrs. Murray.
Aye.
Mr. Sanders.
Aye by proxy.
Mr. Brown.
Aye by proxy.
Mr. Blumenthal. Aye. Ms. Hirono.
Aye by proxy.
Mr. Manchin.
No, because of finances?
Ms. Cinema.
Aye by proxy.
Ms. Hassan.
Aye.
Mr. King.
Crazy.
Mr. Moran.
Aye.
Mr. Bozeman.
Aye by proxy.
Mr. Cassidy. Mr. Rounds. Aye.
Mr. Tillis. Aye. Mr. Sullivan.
Aye by proxy.
Mrs. Blackburn.
Aye by proxy.
Mr. Kramer.
Aye by proxy.
Mr. Tuberville. Aye. Mr. Chairman.
Aye. The motion to approve the major medical leases has passed. No more remaining business for the committee. We will adjourn the business meeting. And I just want to thank all the senators for being here. I very much appreciate you showing up so we could get this done. And Joe, I appreciate you showing up and making your points too, so
Thank
thank
you.
you.
I appreciate being here and being heard, and
Yep.
I would like to talk to
Come
your
back.
financial people.
Count on it.
Yep.
Whoever,
Yep.
they won't raise their hand, but I know they're back there.
They're not here. They're hiding.
Now we'll come out of recess, and Patty Murray has 1 minute.
Well,
to
45
follow up.
seconds, so I'll just ask it really
Yeah.
quickly. In your 25 budget request, you assume that there's going to be 10 on-site centers in 24 and 20 additional in 25. Will VA meet that goal?
Yeah, it is our intent to, yes.
Okay, thank you. Thank you very much, Mr. Chairman.
Senator Moran.
Mr. Secretary, thank you. This question is written as for me to ask you to say yes or no. I dislike doing that to people, but if you can answer it yes or no in a
Okay.
straightforward way, that would be great.
Good.
Could you assure this committee, assure me, that even if the VA acts to incorporate telehealth into access standards, a veteran who prefers an in-person appointment will not lose their opportunity to seek community care if the VA is unable to provide them an in-person appointment within the current access standards?
I think the answer is yes.
Thank you. Same yes or no type question. Would any element of this budget request restrict a veteran's ability to seek care in the community?
No. The veterans are guaranteed that based on the law that you passed in 2018. We anticipate updating parts of that law and the regulations that govern it. But I've committed to you in this hearing room and in private, that when we do that, that will be in the light of day. And that's not necessarily anticipated by the budget request here, by any means.
Mr. Secretary, I'd only highlight for you that while if done in the light of day, that's better than being done in darkness, but I still have concerns about it being done.
I hear you.
So you're-
The way we do it would be by rulemaking, and obviously that would be subject to public comment and everything else. So I guess I want to give you that assurance.
On this growth of employment, employees, you and other veteran leaders, VA leaders, have noted your intent to recapture care in the community due to increased community care budgets. But community care provides needed care access for veterans. If the VA wants to recapture care, VA's focus should be on providing timely, high-quality care to veterans. This is why the decision to implement the goal of net zero growth for the workforce while simultaneously expediting PACT Act eligibility is confusing to me if the VA's goal is also to recapture care and reduce reliance on the community. Can you confirm that any efforts to reduce community care reliance will only include increasing the efficiency of direct care system and not include pulling back veterans' ability to seek community care?
The veterans' ability to seek community care is a statutorily granted question. So I want us at VA to compete apple to apple on that. So that's why, as I said in my opening statement, this year we hope to ensure that every time a veteran qualifies for a referral to the community, we also have a conversation with that veteran to show what is available to him or to her in the direct care system. This is based on not some kind of sociological or ideological view. It's based on what we think is the highest quality engagement for the veteran. And so we want to have the conversation about quality. Veterans are very discerning in their healthcare choices. And I think when given those choices, they'll make the choice that's best for them. This is about quality outcomes for veterans. That's the way we judge ourselves. That's the way, using the V signal, we judge each of our facilities, which is what is the veteran satisfaction with that care. And then when we're competing on that basis, I like our our odds to be able to provide timely access to care, that's high-quality outcomes. And we'll see how that proceeds during the course of this year.
I see it, I think, in at least the way you said it just now, which is we want the VA to provide the best absolute care possible, and then let the veteran make a choice where it is best for him or her to seek that care. Is that true?
That is true, and we think that overwhelmingly the veteran will decide to stay with us. That's what our data suggests to us. That's not the uniform case by any means, but we want to make sure that we're competing there and that we demonstrate the courage of our conviction. Now, I'll just give you an example. In Vision 7, 70% of veterans qualify for a referral based on drive time alone. It's probably roughly similar in Kansas, but I don't have that number. So in those cases, we're making a referral for the veteran to the community. I want us to also tell the veteran, hey, if you want to stay in with us, here's your options if you stay in the VA direct care system. And since we're seeing such amount of change, especially in rural provision of health care in the country, in your state and my state, we think that those are going to be very competitive options, and we want the vets to be able to make that choice.
And those who work for you in VA Central, in the VISN, and in the hospital across Kansas and other states, they understand what you just said is how the VA operates when giving a veteran the opportunity to choose where care occurs. Is that true?
Yeah, we have 451,000 people at VA. They're awesome. They're the best federal workforce, the best portion of the federal workforce that I've experienced by far. So I think, yes, they do believe that. And I want us to just demonstrate the courage of our conviction, which is, hey, they all got in this business to provide care to veterans. Let's make sure that we give vets a good option to come get their care with us.
If my time returns to me, I'll ask you about State Veterans Home.
Good. Thank you. And we can follow up if the time doesn't return to you.
Thank you, Senator Moran. Secretary, I'm going to continue on the community care line.
Please.
It grows between 16 and 20% over the last number of years. At the same time, VA trust scores, which you've already pointed out, continues to measure very, very high, almost 92%. Study after study shows the VA is doing a pretty good job providing health care. In fact, as good as or superior to the private sector. With that as a backdrop, and knowing that this 16 to 20% increase every year is not sustainable, unless you correct me on that, it's not sustainable. What's the VA doing to find the right balance between community care and VA care?
Yeah, thanks very much. I mean, look, we want to make sure that we compete for the veterans' care. And we can compete on quality, and we want to make sure that veterans know that we're invested in their quality. We had a very good couple of years hiring. I just said that we hired net 14,000 nurses in the last 2.5 years. There's no healthcare system in the country that has seen growth like that in its nursing workforce. We're not perfect on nurses, but we have the personnel. And when we have the personnel, we should be able to compete. And when we compete on quality and lay out the options for the veterans, they're discerning choosers, they're discerning participants in their healthcare choices. When we're operating on that level, I feel really good about our opportunities to get this to the right place. Okay. At the end of the day, VA has always relied on the community, and by the way, the community always relied on VA. We just got to make sure that this is a decision about quality outcomes for veterans, quality health outcomes for veterans, rather than simply a question of convenience.
The chair, the ranking member, give you an upgrade. The ranking member, talked about emergency care being a main driver of community care costs, overall spending. 30%, in fact, I believe is what the figures show. Go down the same line that Jerry talked about in his open statement. Is the VA reviewing emergency care utilization, how to manage it, how to recapture some of those vets, get them back into direct care? And let me know what you're doing about that, because 30% driver, that could have a major impact.
Yeah, well, look, I mean, first, we want vets to make sure that they're having a relationship with their primary care provider. When they need to see emergency care, they should see it. But if they need to see their primary care docs and make sure that they're managing their health care over time, that's first best, because that allows us to coordinate that care, one. Two, we are in the field with one of our more innovative updates, I think, which is called tele-emergency care. A veteran can arrive at tele-emergency care through our Veteran Health Connect. Veteran Health Connect last year had 40 million enterprise-wide calls in the VA system. This is like something that's available to each one of us. Well, you guys have special access to care, but available to us at Blue Cross Blue Shield. You call the nurse practitioner to triage, right? You call that, you can get connected to telehealth, emergency care with a trained emergency provider. You can discern whether what you're experiencing is actually an emergency. Since October, we've seen roughly 16,000 cases. Of that, 60% of those resolved, had issues resolved on the phone, and the median time for that interaction is 10 minutes. So the veteran doesn't have to get in his car, doesn't have to drive and sit in an emergency room, and ends up having his issue resolved in 30 minutes or less. Those are the kinds of innovations that we want to make sure are happening. The alternative is the veteran goes to an emergency department. The incentives in the private system are for the veteran to be then checked into the hospital. And then we risk being in a situation where we're overutilizing care, where the veteran's getting care that's not good for the veteran, is exposing the veteran to infection and further sickness. Let's make sure that we get the veteran the care they need, when they need it, where they need it, and tele-emergency care is a good example of that.
Senator Tuberville.
Thank you, Mr. Secretary. Thanks for being
Sir.
here. In Alabama, we're having huge problems with doctors' exhaustion, nurse exhaustion. Lines are long.
Yes.
You hearing that?
Yeah, well, interestingly, in our most recent surveys, veteran burnout is down on our employee engagement surveys. That's a good thing. That has to do a lot with the generous authorities you've given us for pay increases and some decisions that we're making about how we're treating veterans. So we feel much better this year than I did a year ago when I was talking to you.
So your recruiting nurses and doctors is improving, down, up, since COVID? You know, I understand the problems.
Up.
Up.
Not only is recruiting improving, but retention is at historic highs.
Yeah. I had a situation in Tuscaloosa, my VA over there.
Yes.
Gentleman basically had to have some special service done.
Yes.
Approved. A few days later, they called me, you can't do it. You can't do community care in town. You've got to go 150 miles away. What rules and regulations do your doctors and administrators go by when it comes from VA care to community care? I mean, does it have to be approved by somebody? Does it have to go up the chain? Are they set by you, your staff?
Well, they're set by regulation and by the law.
Yeah.
And so it depends on what exactly this engagement was, and I'd obviously love to follow up directly with you and with that veteran on it. It has to do with, A, is it in the first instance primary care or is it specialty care? Then it has to do with where that veteran's home is and how far is that home from Tuscaloosa. Is, you know, in your state and in your vision, entirely 70% of veterans are eligible right now. In New Hampshire and in Alaska, it's 100% of veterans because there's no full service hospital. Mm-hmm. So if that's the case, if you're 30 minutes from a facility for primary care, you qualify off the bat, irrespective of whether the private provider is 45 minutes from where you are or 60 minutes from where you are. So we just got to do a better job of making sure that the veteran has an informed choice.
Good. Let me ask you about this one. This is kind of old news here. You know, the VA came to a settlement with the union.
Yeah.
related to the termination of employment of approximately, 4,000 people?
Yes.
Who had been fired under the accountability authority enforced by President Trump.
Right.
Through Congress. In some instances, they were terminated because of egregious, criminal
Right.
negligence.
Right.
But they've been brought back, correct?
Not entirely correct. The action that was taken that you referred to was subject to both administrative body review, so Merit System Protection Board, National Labor Relations Board, and subject to federal judicial ruling, leaving us really very little option to manage. So what I did is I engaged in a settlement arrangement with the union where I said those employees alleged to have carried out, as you said, egregious activity would not be welcomed back.
Good.
And so they are not welcomed back. So I could get you the exact numbers of the 4,000. It's, we can get you an update. I think we're keeping your teams pretty well updated on those numbers over time. But those, again, by virtue of the fact that we're before administrative bodies and federal courts, that settlement includes a lot of things that, we wouldn't necessarily choose to do of our own accord, to include back pay, things like that. But bringing these employees back who are charged with egregious misconduct was not something I would agree to.
You basically went case by case and looked at it?
Correct.
Yeah,
And we fought that out.
which is important to the veteran.
Correct.
We don't put anybody in harm's way. Still hadn't got the accounting of abortion in the VA. If you
Yeah.
get that to me.
I did promise you that, but I've also ascertained that we've given those numbers, I think, relatively recently to the committee. And since generally that's the kind of information that we treat that we would require a chairman or ranking member letter on, we've also communicated to your team that that's available to the committee, and we'll get you those updated numbers.
Well, I appreciate it. The chairman doesn't like people from Alabama, so he didn't pass that down the line.
Did you refer to Tuscaloosa sometime in your questioning there? And what kind of football team they have there? I was just wondering if you expected.
Used to be pretty good. We lost our coach.
Senator
Thank
King.
you.
Thank you, Mr. Secretary. I want to start with a couple of compliments. Last week, I was at the ribbon cutting and the opening of a new CBOC in Presque Isle, Maine.
Awesome.
And to give you an idea of where Presque Isle, Maine is, Portland, Maine is about halfway between Presque Isle and New York City.
Wow.
So we're talking far north.
Way up
country.
there.
It was wonderful. The design was almost identical to the one that we toured last year in Rumford. Just a fantastic facility. And
Good.
your staff in Maine, your medical staff, Tracy Davis at Togus, and her support are really fabulous.
We're really
people.
proud of them.
You should be. They're great, and I've never heard a negative word from a veteran in Maine about the treatment. Second compliment, if you've onboarded 14,000 nurses in the last couple of years, you're doing something really good.
Well,
Because
you're
there's
doing it. You gave us the authorities to pay them. and
Well, there's a
that's what that is.
nationwide nursing shortage, and it's amazing.
We're really
to be able
thrilled
to
about it.
accomplish that. That's fabulous. Now, on the negative side, as you know, there's a provision in your budget that sees a reduction in staff of about 10,000. How do you justify that in terms of the growth and demand for services? How do we be confident in this committee that we're not sacrificing the quality of service to our veterans if we're reducing staff?
Yeah.
At the same time, demand is going up.
Look, the budget, the budget here reflects the budget agreement, the bipartisan budget agreement, and I think it's generous to VA, but it does force some choices on us, and we've put those choices in black and white in the budget. One. Two, we do believe that because of the strength of the hiring in the last couple of years, that we, in particular, are better, not 100%, obviously, but better sourced with clinicians. The nurses are an example of that. Three, we have tested this proposition with access sprints since last October. And between October and February, we saw 25,000 more new veterans, unique new veterans, for care than we did a year ago. That is because in that
That's a good thing. I just want to be sure you have the staff to serve them.
Right, and that's because we did evening clinics, weekend clinics. And fourth point is, as the chairman pointed out in his opening comments with mental health care, we do have a goal of net zero FTE during the course of the next year. That's to manage
in mental
through
health?
attrition. No, sorry, just in overall
Okay.
healthcare. We can manage that through attrition, we believe. And we can continue to strategically hire where we need care provision. For example, on mental health care. Or recently, I talked with our VISN director in Texas, who, working with our hospital director in San Antonio, made a decision to hire 2 GI docs, which they'd been looking for 3 years. That's strategic hiring.
Let me change the subject, and these are 2 suggestions that are policy, but could end up actually saving money
Yes.
and treating veterans. 90+% of seniors want to stay in their houses as long as they possibly
Yes.
can. I've never had anybody raise their hand and say, I want to go to a nursing home. And yet, 55% of your geriatric and extended care goes into institutions. I hope you can take a look at that and think about how do you change the environment in people's homes so they can stay longer.
Yes.
Grab bars, non-skid mats on the floor, those kinds of things, because people would rather stay in their homes, and it's a lot cheaper for the taxpayers if they stay in their homes. So I hope that's something you'll look at, because if we want to keep people in their homes, we ought to be putting more money into what amounts to prevention.
Yeah, I think we're there. Maybe not as much as you want to see or as much as I want to see, but we're bending that curve up. Home-based primary care is one of our fastest growing interventions. That's a place where we're hiring a lot of those nurses I talked about. And if you look, just to go back to this question about primary community care, after emergency care, the next 2 or 3 highest investments in community care are various manifestations of home-based care.
Good.
I think that's an example where community care allows us to skate to the puck here.
Yep.
And by the way, save money over time for taxpayers.
I'm out of time, but I want to follow up on this, and we'll follow up for the record. I'm going to be introducing legislation to have you take a special focus on falls.
Yes.
Huge issue. Medicaid, Medicare spend $38 billion a year treating falls, that many of them can be prevented.
Yes.
So I want to follow up with you, and
Good.
I hope you'll keep an open mind, because this is a way, it's a lot cheaper to buy somebody a bath mat than to fix a broken hip.
Some of our best innovations in our innovation office are around these manifestations, including new AI innovations that track gait of a veteran. So these are things that we'd be more than happy to have that conversation with.
Thank you, Mr. Chairman.
With my apologies, Senator Cassidy.
Thank you, Mr. Secretary. You mentioned that you've hired 14,000 nurses. On net, how many more nurses do you have in the system, knowing that there's been attrition?
Right, so that's a net number. So that's a net increase of 14,000 in
So
that
let me
period. The number we've hired is going to be substantially more than that, given the churn, especially in 2022. Remember 2021,
I got that. Hang on, I got limited time. So on your red team, I didn't mean to be rude.
Yep.
On your red team analysis you gave us, you mentioned that there is anecdotal reports that that the increased number of veterans to community care providers is adversely impacting some VHA graduate medical education programs. Now, what I know that to mean is that there's fewer patients
Correct.
in the hospital.
That's what I understand. By the way, I think your staff gave you that. I still have not seen that report, but I'm glad you've seen it. But
I think it's generated by your folks.
well, it's generated by our red team that we asked to stand up to take an independent look at what's happening. I still haven't seen it, but it sounds like you guys have, and I think that's a good thing.
Now, if there's fewer patients, there's less staffing required, theoretically. Knowing that the union seems to be particularly strong with the VA, are you allowed to decrease staffing if you don't have patients in the bed? Do you follow what I'm saying?
I do.
Do you still
Yeah.
have the ward clerk there? Do you still have the nurses there, even though there aren't any patients?
No, I mean, like, this is.
Are you sure about that?
I'll make sure that I come back to you on it, but we're in this budget, we're managing our workforce to try to meet the budget targets that are laid out in the bipartisan
But I'm just so
agreement.
struck that the unions are so powerful that I just want to be comfortable that you're actually adjusting your staffing, because if the residents don't have enough patients to see, but you're still short on nurses, then that, somehow this is not all kind of connecting in my brain.
Remember that, I'd have to ask the red team members about that, and maybe you could if you meet with them. But whether there's enough patients in the hospitals could be a function of community care, could also be a function of more outpatient.
They say specifically community care.
Yeah, so it could be a function of more reliance on outpatient care.
Can I move on? Prior auth, we've talked about that, and I kind
Yes.
of mentioned I've been interested, and I've been interested in prior authorization, and the VA frankly always tells me they're getting to it, but it doesn't seem like it's ever gotten to.
Yeah,
So knowing that if it goes to a community care and there's no prior auth, in the private hospital, in the private insurance experience, oftentimes there's overutilization of tests.
yeah.
So, one, have you found increased intensity of services for the same diagnosis in the community care versus the VA? And two, where are we in terms of instituting a prior authorization process?
Yeah, so we do see some evidence of multiple tests for the same diagnosis, and that's a function of our not doing a better job of coordinating the care when we send it out. We don't do a good job of following up to get the radiology report or something like that. So that's mostly on us, but we ought to do a better job of that. Second, our prior authorizations, we do a pretty good job of this in dental, by the way, and so that's worth looking at. But we, going back to 2019, do standard episodes of care. And we, for example, cardiology appointments may come with 10, 12 standard episodes of care. And what we,
When you say episode of care, you mean visits to the doctor's office?
could be, after a shoulder replacement, then you're going to have PT associated with that. So it's the shoulder operation
But
plus the PT.
let me kind of put a point on what my question is.
Right.
There's some, it's a fraction, but it's a small fraction, but it's an expensive fraction. If you send the patient to that doctor, every test that's in that doctor's office is going to be ordered,
Correct.
whether indicated or not.
Correct.
And the point of prior authorization is to prevent that overutilization.
Correct.
And so where are we in terms of prior authorization, in terms of preventing that sort of sometimes harmful activity, always expensive?
Yeah, sometimes harmful, always expensive. That's why we're looking at the standard episodes of care, because it's often under that with these extra diagnostics are asked for, or in the instance of cardiology where we've looked at 300 COCs since 2019, we've seen almost a 20% increase in the use of catheters, the imposition of catheters, for example, in the community, when during the same period we have a 30 to 40% reduction in the use of catheters in the VA system. So something is different there. That's prior authorization.
That's suggesting to me that there is not a prior authorization. If we're going to do a catheterization, the VA has to approve it. Rather,
Correct.
if the doctor wants to do it, the doctor can do it.
Correct. Because of our reliance on standard episodes of care, that's what ends up happening too
Now,
often.
I will say, I think it's been 1.5 years to 2 years that I've been told that the VA is trying to put in a system to address that. And I can just tell you that that's going to be, again, expensive and sometimes
Yep.
harmful. So, and that would be a way to rein in the cost of
Agreed.
some of this community.
This is among the things that we'll be looking at as we're looking at each of these questions, given that the rapid growth in community care and then the rapid rise in cost overall in healthcare. If, as I said to a couple of you guys on the phone, if we were growing at 15% and we weren't looking at it, I think you would ask me what's going on. So we're trying to get our hands around each of these things. Whether it's me who's overpromised to you on prior authorizations, I apologize for that, but I'll make sure that we stay on top of that.
Okay, thank you. I yield.
Thanks, Chairman. Good afternoon. Thank you for your great work.
Thank you.
Mr. Secretary, and thank you to the many, many men and women who work in the VA.
They're the best.
Unsung heroes, and I know how hard they work to deliver benefits, health care, and service to our veterans. I want to ask, first of all, I appreciate what you're doing on the New Haven facility. Money's in the budget. We need
Yep.
to do the authorization.
Definitely.
And rather than berating you on that topic, I'm very glad to be thanking you for the,
Well, I think it's you all who did it, so,
well, with your leadership. I want to ask you about the PAC Act. I noted 1.3 million claims, about 1.149 processed and completed. I may have missed it in the testimony, but how many of those have been approved or disapproved, if you have a breakdown?
yeah, about 950,000 or so have been granted. So we're at a grant rate of about between 70 and 75%, which is the beauty of the presumed service connection.
That is really the beauty of it.
Yeah.
And I am wondering what you anticipate will be necessary by way of outreach to the many veterans who may not know about the PAC Act or about the expansion of it. And I was really just overjoyed to see the expansion.
Well, so we have 550 outreach events scheduled yet this year. And so we think that there are still a lot of veterans who don't know that they've qualified for this additional care and or additional options for benefits. And importantly, you'll recall that in the run-up to last year's August 9th deadline, we reminded veterans that establishing an intent to file by August 9th protected that August 10th, 2022 effective date, provided once you establish that intent to file, in the next year you file a claim. So we're readying an outreach plan right now where we would go back to each of the people who have filed an intent to file to urge them to turn that intent to file into an actual claim before August 9th again. Because what that will do is that will protect their August 10, 2022 effective date, which will be a meaningful benefit to those veterans who get their service connection rating as a result of the PACT Act. So not only are we reaching out to veterans who don't yet know, we are reaching out to veterans who have filed an intent to file, which as near as I can tell, there's no evidence of VA ever having done that before.
That's great. If you could let me know about events that you're planning in Connecticut.
Count on that.
I would love to be involved to help elevate them and help with the outreach.
Count on that.
Great.
Yep.
Let me ask about a painful but perennial topic, veteran suicide.
Yes.
Are we making any progress? I know the numbers are still too high. How do you feel about how the VA is doing?
Well, the numbers went up last year for the first time in several years. And that is heartbreaking. We also, I just want to underscore one more time that any individual veteran suicide is one too many. This budget is generous as it relates to suicide prevention. You all have been very generous as it relates to suicide prevention, including in giving us new authorities, particularly under the Staff Sergeant Fox local grant program, which allows us to make investments in local organizations in each of your states who know your veterans best. And I think that's a positive thing. You've also given us the Compact Act in the last 2 years that allows any veteran who's experiencing acute mental health crisis to go into any hospital, irrespective of his enrollment status with VA. So any VA hospital, any private hospital, and to get care that day, and we pay for that. In the first year of that, just over a year of that, 47,000, almost 48,000 veterans have taken advantage of that. It's heartbreaking that there's still that many veterans who have to avail themselves of that service, but it's there. So the tools are there, but the challenge is still a major one, and we'll stay on top of it until there's none.
Thank you. My time has expired. I just want to thank you for the work that you're doing, particularly on women's health care in the VA. Thanks.
Senator Tillis.
Secretary McDonough, thank you for the time on
Thank
the
you.
phone earlier this week.
Thank
I
you.
appreciate it. And you really stand out as one of the more accessible members of the administration. I really appreciate your work. We had the vote earlier about the lease, and I was a little bit jealous when I heard all those southern states listed and North Carolina not on it. As you know, we had a lease, I believe, submitted for Jacksonville, didn't make
Yeah.
the cut.
Not yet. We're still working it, but not yet.
Can I just get a commitment to get a debrief, figure out what we can do to
100%.
help on that
You got my
specific
commitment.
matter?
Yeah.
And I think it's also, in talking with the visiting director, we talked about the broader issue of how do we get the brick and mortar facilities in place to meet the increasing demand, particularly in a state like North Carolina, which is growing by leaps and bounds.
Massively.
In terms of veterans population. And what more, the question I have is, do you already have the authorities to come up with some creative ways for joint use, either with the DHA or with the private sector? When I was on Senate Armed Services, we started doing some relationships with the private sector, the trauma center down at Camp Lejeune. We ended up getting into a public-private partnership there. And what more should we be doing, and what more authorities do you need to do that kind of stuff?
Yeah, so I think we have a lot of authorities that we're now starting to exercise. The most important is working with DHA, with DOD. So we're having actually a summit in your state later this summer on that, where we're trying to turbocharge our efforts there. We just announced a new facility up in the Hudson Valley in New York, where we're seeing jointly VA, veterans, and active duty. I think we have to make better use of that. We're also in your state working with USDA-supported community hospitals to make clinical space available where we can afford to deploy care teams to see veterans.
But
in
you
settings
feel
like
you
that.
feel like then you don't need any more authority. You just need to better exploit or use the authorities you have. Or are there any sticking points or things that we could do that could facilitate the process?
You know, aside from the leases, you just did us a big solid on the leases you just did.
Yeah.
We might have to come back to you and ask that you reauthorize at a higher cost level the leases we talked about earlier in the week, because of the high interest rates. We've seen them anywhere from 60 to 150% above the authorized level, which we can't do under current law. My theory is we really just, at the end of the day, need dollars. And we want to prove to you that we've exhausted remedy using all of our authority. So this DOD cooperation, the USDA cooperation, our academic partner cooperation in your state in particular, working with Duke, is a really good example. And then, you know, maximizing community care. When we've done all those things, then we can come to you and say, listen, I know it's like $1.5 to $2 billion a hospital, but we've done everything else. We only can now do the
Well,
hospital.
I just think creatively for North Carolina in particular, because I'm happy to help with the state legislature and the governor's office to come up with creative ways for our state legislature to get engaged. We've done that with the DOD and the Department of Navy in the past, and I'd like to see if we can help you. When you and I talked, I discussed I see your budget requests. I see that you're managing some of the position cuts through attrition. But at the end of the day, you've got some future requirements that are going to outstrip your current funding stream. So how do we get ahead of, before it just becomes this, we're flogging you because you're not hitting service levels, and you're not hitting service levels because you don't have the funding till that you need it for policies that we passed. Tell me a little bit about what we should be thinking about now. You know, it was not a vote that I was happy with, but I voted against the PACT Act because I didn't think it was fully ready for prime time. Now I'm here to help get it implemented, and it is one of several areas that I think are stressors that could affect provision of care to veterans. So what do we need to be concerned with and step up to make sure that gets implemented?
Well, what I'm challenging our agency to do is to manage the dollars that we have now, mindful that we're operating under a capped budget. And that means that, you know, we have two big costs in the VHA side, which is one is the cost of the care, the provision of the care in the direct care system. So that's people. and then what we pay to purchase the care. And so we're mining both of those things, and we're trying to demonstrate that we can manage that well. Meanwhile, we have a really big opportunity and challenge in the PACT Act that says we can either go ask Congress for more money because we can't manage either the workforce number or the provision of the care, or we can go to Congress and ask for more money because we have more veterans in our care. And that's what we're doing now. As I said, 12,500 new veterans just since March 5th alone. So I feel much better coming to have a conversation with you to say, hey, we're managing the workforce levels here. We're managing access to care, care utilization, and we're doing that around quality. And by the way, more veterans are choosing to get their care with us because they do see that there is a care, they can leverage greater care, quality of care at VA. That's what our goal is here. Now, it's facilitated by the fact that, or necessitated by the fact that we're now operating under a budget cap. But you know what? You've done this in a lot of different places. You got to manage your operation through the budget, and that's true in the government as well. But again, if we need to ask for more money, which we may, I'd much rather do that because we have more veterans than because we are not able to manage our system.
Thank you. Thank you, Mr. Chair.
Senator Hassan.
Thanks, Mr. Chair, and thank you, Mr. Secretary, for being here, for the work you're doing, and for the work that your entire team does.
Thank you.
Our veterans are better for it. You mentioned that New Hampshire doesn't have a full-service hospital, along with Alaska, and you and I have had several discussions that not only do we don't have the full-service hospital, but we have a really aging facility in Manchester. Yes. We have needed repairs and upgrades. It's a 70-year-old facility, and the services for New Hampshire veterans have been disrupted by issues such as flood damage from pipes that burst in 2022. And you always have this kind of sense of, are we going to keep doing this with this 70-year-old facility? Is it a facility that we can really make sound, right? So we've had these discussions. As a result, we asked for a multi-year plan to improve this facility, publicly released. I'm really glad you guys released that last September. And I know that the VA has been working towards goals laid out in the plan. In fact, you broke ground on the Women's Veterans Health Clinic in Manchester last Wednesday. So congratulations on that step. But I just want to follow up today to get a detailed sense from you on the timeline for several projects in that multi-year plan. Can you give us a sense of when the Women's Veterans Clinic will be complete? And can you tell me what the next two projects slated for completion are and what their timelines are?
Yeah, thank you very much. And you're generous to congratulate us on it, but it's just because you and your fellow senator have kept the heat on, and the delegation have kept the heat on us. So the Women Veteran Health Clinic is slated to open in fall 2025. The next two projects are the renovation of the new lab suite. We awarded that. We will award that in summer.
Okay.
And that will be completed in spring 2025. Mm-hmm. And then the specialty care clinic, it's a minor construction project. So that's, you all did us a big solid, by the way, by raising the threshold for minor construction projects up to $30 million in the defense authorization bill. That's a major help to us. That specialty care clinic will have audiology and optometry. That will also be awarded this summer, and we anticipate completing that fall 2026. So the demolition of several outbuildings will be awarded in 2024 to make room for that. So we should see progress on that as well.
Thank you, and we will keep in touch about it. And it's really important that we have these discussions publicly so New Hampshire veterans can get a sense of what's in store. I'm also going to take a minute to repeat something you know, but I think veterans need to hear over and over and over again, which is thanks to the PACT Act and the VA's decision to expedite enrollment eligibility, veterans who were exposed to toxins, as well as veterans who served in the Vietnam War, Gulf War, Iraq, Afghanistan, the global war on terror, or any combat zone after 9/11 are now eligible to enroll in VA healthcare. And I've just been trying to get that message out, as I know you have been. Now that we're providing care for these veterans, to Senator Tillis's point, we have to make sure we can do it for as long as they need. So just to build on the discussion you had, and you don't have to repeat anything, but what is VA doing to ensure that it can support and provide top quality care for PACT Act veterans now and into the future?
Yeah, well, so look, again, there's no doubt that we are going out to get new veterans into the system. And we're going to let that, because the alternative is we hope that we get the investments in the system and then we can lure the veterans. I think the better investment is to take advantage of this terrific opportunity, the PACT Act, to get more veterans into our care. So how are we going to do that? Well, we are tracking with each of our VISNs at a VISN level what their spend is every month, what their enrollment is every month, and what their FTE count is every month. And it's our intention to make all that information available to your staff so that you can follow right along with us and hold us to account on that. As we have more robust patient census counts, and we lay that against our access efforts, and those access sprints are in large measure those innovations we took, we put in place last October. Many VISNs are maintaining those, night clinics, weekend clinics. And so we should be able to watch this develop and be in a position to make sure that we have the people in the space to take care of those vets.
Well, excellent. And I see that I am out of time. I'm going to follow up with you on work that the VA is doing to support surviving spouses, because obviously spouses are part of the service too. I have a couple of bills that address helping surviving spouses get some of the benefits that the veteran themselves gets, and just would like to follow up with you and your team about that.
There's no question we can do a better job on spouses and on survivors than we've done. We're working with the VSOs on that. We're trying to learn that, and directly with survivors with surviving spouses. So we welcome any further help you can give us on that.
Thank you. Thank you, Mr. Chair.
Senator Sullivan.
Thank you, Mr. Chairman. Mr. Secretary, good chatting with you yesterday. Appreciated the time. I wanted to follow up on some of the topics we talked about. One is this issue of the cemetery formulas that go to helping communities establish veteran VA-based cemeteries. As I mentioned to you, with the exception of Metlakatla, which is our only Indian reservation in Alaska, we've actually never been granted that ever, which is kind of shocking given that we have more vets per capita in the state in the country. Undersecretary Quinn, when he testified a couple months ago, was pretty forward-leaning, saying, hey, we'll take a look at that, Senator, because a lot of our formulas have been focused on maintenance of current cemeteries. We haven't done much, although the program allows for money that goes into new cemeteries. As I mentioned, great veteran group in Fairbanks, Alaska has got land, selected land, bought land, and now they're trying to get a grant. And I'd like to just get your commitment. You probably can't say, all right, they're going to get it, but Undersecretary Quinn was pretty forward-leaning on that topic, just to make sure you're not just doing it for maintenance. It can go to new programs like the people in my state who are working hard on this. And like I said, we've never gotten one.
Yeah. Well, so we have this goal to increase the number of cemeteries within 75 miles of veterans and survivors so that survivors can visit their veteran. It's consistent with that goal to make sure that we're leaning in a place like Alaska, which is not only got a lot of vets, but it's got a lot of surface area. So we'll make sure that we're biasing toward that outcome. I want to be careful to not overpromise, but I get it. I understood the arguments made yesterday. I talked to Matt about them.
Oh, good.
And, we'll lose Matt, unfortunately, at the end of this May.
Yeah, well, he's doing a good job.
But you've got my commitment to stay on top of it.
Great, thank you. Next one we talked about, look, we were talking a lot about the PACT Act. One of the big flaws was the Camp Lejeune component of that, which did not have trial lawyer contingency fee caps. To his credit, the Attorney General of the United States went and looked at the existing law and came back and said the Federal Tort Claims Act actually covers this. So the announcement made by him, you, Secretary of the Navy, Del Toro, was very helpful. I was disappointed. My team, mentioned to me, I would have mentioned on our call, we had asked a number of questions of the VA on this topic last year. We just got the answers yesterday, and you guys essentially didn't take a position. I hope you can be a little bit more forward-leaning the way the Attorney General was. Here's the issue. Despite you guys, Secretary of the Navy, the AG saying, hey, veterans of America, Camp Lejeune veterans, don't do anything above 20 or 25%. Matter of fact, the Attorney General of the United States said any law firm charging above that is subject to civil and criminal liabilities. But, some people don't follow the law. Saddle Rock Legal Group, the AVA Law Group based in Montana, just recently my team was looking into these guys. Are advertising on TV. They're still charging 60% contingency fees. The American Legion, the VFW made this their #1 issue, to get these law firms to stop ripping off the families of sick Marines. And we solved it. But guess what? These law firms don't give a damn. They don't give a damn what the Attorney General says. We're reporting them to the Attorney General. I hope he smacks them with criminal penalties. 60%. That's like highway robbery against veterans. So, Mr. Secretary, can you commit to me to continue to work with us, but also, importantly, have at the local VA offices on your website, which I think you already do, veterans, you should not sign up for anything more than 25%. It's against the law. And don't get ripped off by these unscrupulous law firms. So can you kind of strongly stand?
Yeah, as I told you, and we discussed when the Attorney General did what he did, that we supported him in that. We think this is the right thing to do to make sure that vets get their
fair share.
Their fair share. Yeah.
Can you commit, though, to keep, you guys have a great network with veterans, VSOs, like I said, American Legion, VFW made this their top priority. Keep trying to get the word out.
We'll keep pushing.
I saw these ads on TV like 3 weeks ago, as I mentioned to you, and it's just like, come on, right? Really? These cockroaches are trying to take money from sick Marines and their families? It's just wrong. It's wrong. Gosh, it's wrong. Let me just make one final quick question. I know on the community care, a lot of discussion on that. Secretary Hassan mentioned Alaska, New Hampshire as not having full-service hospitals. Can I get just, maybe not right now unless you have it, an update? There was expansion plans for VA facilities, not hospitals, but clinics in Fairbanks, in Anchorage, in the Mat-Su Valley, on the Kenai Peninsula, Homer, Juneau. And what I'm concerned about, Ms. Secretary, is you guys are looking to cut back on staffing. In Alaska, what's worked is actually getting more staffing as we've built up these facilities. Like North Carolina, we're seeing a big increase in our veteran population in our state.
It's good.
So can you make sure, as you're trying to right-size more broadly, that the places where your facilities are increasing, the veteran population is increasing, that you're not cutting there? We want more VA officials, doctors, nurses. We love them in Alaska. As I mentioned, our referral backlog alone, which is quite big, I mentioned the number 10,000, is important to make sure we continue to have robust staffing as we're growing out the VA, not cuts.
Yeah, so I had a good conversation with our VISN lead. They've really appreciated the engagement with you on that. So just two things. On the infrastructure, I'll be more than happy to talk to you about our infrastructure plan for Alaska.
Good.
We're not backing off that.
Thank you.
We're trying, as I said, we're trying to skate to the puck. As I told Senator Tillis, exercising every authority we have and being really creative about it. The next place to do this is J-Bear.
Great.
And so there's no reason that we should be sending vets downtown and active duty docs downtown to operate on vets down there. We can do that right at J-Bear and save the taxpayer a lot of money. So we're not backing off the infrastructure plan. On the backlog, we've seen substantial improvement since February. In large measure,
still, it's really big, though, as you have to acknowledge.
No, I'm not saying it's not. But I don't see that number that you talked about, but I'm gonna leave this with you so that we're on the same page.
Okay.
And so I can find out if I'm looking at the wrong thing. In large measure, we've been able to do that by ramping up MSAs. Okay, so those are the schedulers who help make those appointments. Yeah,
Who need to be based in Alaska.
exactly. And so that's an example of strategic hiring where we need those kinds of personnel. You know, we're gonna make those decisions, right? But again, when you're operating under a cap, you gotta balance this somewhere. We put out the trade-offs in the budget, but we're making good progress here, working together with you guys. We're gonna stay on top of it.
Okay,
And
thank you.
again, we're not walking back from our infrastructure investments. We just have to prove to you guys that we're really serious and we've done everything we can. And then we're gonna come and say, hey, we need the whatever, the $2 billion per copy for hospitals. That's gonna be really expensive. But I don't feel right that we should come to you with an aggressive ask like that until we've done every single creative thing we can.
Great. Thank you, Ms. Secretary. Thank you, Mr. Chairman.
Yep, before we conclude the first panel, I feel for tradition's sake, I've got to recognize Tillis just for 5 seconds.
Thank you, Mr. Chair. Senator Sullivan and I served together for 8 years on Senate Armed Services, and he's repeatedly quotes on a per capita basis, Alaska has more veterans. I remind Senator Sullivan that we have more veterans than he has people. And if you were to cut my veterans population in half, we'd still have more veterans.
All right, well, but it's true, Mr. Secretary, we have more veterans per capita. I think Montana's second, but Alaska's number one.
7,000 veterans a month in North Carolina, August, September, October last year. 7,000 a month, new ones.
Good. Well, we just want to keep the predictability of the committee. So with that, thank you, Secretary McDonough.
Thank you, Mr. Chairman.
I will say this at the end of the hearing, but there will be questions. I would ask that you and your team answer them as
We'll get them back to you before a year from now.
quick as you can. Thank you very much.
Thank you.
Now we're going to hear from 3 veteran service organizations responsible for the independent budget. I want to introduce the folks on this next panel. Christina Keenan, all these folks are familiar to the committee, by the way. Christina Keenan, Deputy Director of the National Legislative Service at VFW. We have Roscoe Butler, Senior High Policy Advisor for Paralyzed Veterans of America. And last but certainly not least, we have Shane Learman, who's the Deputy National Legislative Director for Disabled American Veterans. I'm going to give you guys 2 minutes, but it'll be I'm not going to drop the gavel on you, all right? So make it quick, though, if you can, because we appreciate your input. It's very, very important. And please know this, just because it's Tillis and I are here, the people that really do the work are the folks that sit behind us. And so we appreciate you being here. And Christina, you have the floor.
Chairman Tester and members of the committee, on behalf of the Independent Budget Veteran Service Organizations, DAV, PVA, and VFW, thank you for the opportunity to present our recommendations for fiscal years 2025-2026. For more than 30 years, the IBVSOs have provided independent budget recommendations to ensure that VA remains fully funded and capable of carrying out its mission. First, it's important to note that VA's full-year appropriation was not enacted until half the year had passed. The routine use of continuing resolutions limits VA's ability to expand access to benefits and services for veterans. Congress must do better. A critical component of VA's health care delivery is its infrastructure. We're concerned that VA's request for major and minor construction is 1/3 lower than what VA requested last year and far below what is necessary. It's important to have modern and up-to-date facilities. We recommend $5.2 billion for major construction, more than 4 times the current funding, and $910 million for minor construction, a 30% increase. VA infrastructure funding has remained stagnant for far too long. In the past 10 years, it has only increased 5%. Meanwhile, the construction backlog has grown exponentially, 116% since 2014. Funding must increase to keep up. Private healthcare, on the other hand, invests considerably more into the infrastructure of their networks. Last Congress, Kaiser Permanente testified before this committee that they invest about 3% of their overall operating budget into infrastructure. VA invests about 1%. Unless there's a drastic increase in resources for VA, we will continue to see this backlog grow. Infrastructure costs have increased year after year, and they will not get any less expensive over time. I will now turn over to Roscoe Butler from PVA to present our recommendations for VA healthcare.
Thank you for the opportunity to discuss the independent budget's recommendations for VA medical services for fiscal year 2025. As noted in the independent budget Veteran Service Organization's written statement, the IBVSOs recommended approximately $151.8 billion in total resources for VA medical care for fiscal year FY25 appropriations. Our FY 2025 recommendation primarily reflects the increased funding baseline for all medical care programs established over the past 3 years, continuing enrollment increases, continuing inflation, a federal pay raise, and increased workloads. However, I would like to address some funding concerns the IB identified with funding trends in the VA's budget. Over the past decade, VA's reliance on community care has risen dramatically. While we agree that veterans must have non-VA options to fill gaps in care, we believe VA must remain the primary provider and coordinator of veterans care. While VA is requesting an overall increase for medical care, the community care program is growing at a faster rate than VA direct care. In addition, VA's request would cut 10,000 healthcare FTE, including 600 physicians, 2,400 nurses, 500 non-physician providers, and over 2,000 healthcare technicians, despite VA's reporting more than 66,000 healthcare vacancies at the start of the year. We should not be cutting positions when we can't even fill the ones that are already there. Also, we are concerned with VA's projected use of $12.7 billion in carryover funding rather than requesting new discretionary appropriations. If VA's unobligated balance at the end of FY24 is less than projected, it could trigger a funding shortfall next year. This concludes my oral statement. Now, Mr. Lieberman from DAV will speak briefly about our funding recommendations for VA benefits and services.
Veterans submitted over 2.4 million claims in fiscal year 23 for benefits, primarily disability compensation, which is 39% higher than the prior year. The Veterans Benefits Administration processed 1.9 million benefits claims in fiscal year 23, surpassing the previous all-time record by 16%. As of April 28th, just a few days ago, there are over 946,000 claims pending within VBA. 32% of them are considered backlogged. Therefore, it is critical that VBA be appropriately funded, and the IBVSOs recommend a total of $6.2 billion for VBA in fiscal year 25, a 9% increase. This includes plus-ups for more employees, as well as $130 million for overtime to process the backlog and pending claims. The Board of Veterans' Appeals continues to resolve more appeals in recent years, yet at the start of fiscal year 24, there were over 200,000 appeals pending. 72,000 of those were awaiting hearings. Additionally, we are concerned that the board conducted 11,000 fewer hearings in fiscal year 23 than before. For fiscal year 25, the IBVSOs recommend $333 million for the board, a 14% increase, which includes a plus-up of 220 new FTE to address the backlogs of appeals and hearings. In closing, we believe that the greatest roadblock to properly funding veterans' benefits and services comes from budgetary enforcement mechanisms designed to limit federal spending. To ensure that our nation meets its sacred obligation and its moral imperative to our nation's veterans, We call on Congress to exempt veterans programs, services, and benefits from congressional pay-go and cut-go rules, as well as work to eliminate the use of CRs for VA care and services. Mr. Chairman, that concludes our testimony. We are prepared to answer any questions you may have.
Thank all three of you for being here and for your testimony. And Shane, I think your last statement really speaks more to dysfunction in Congress than anything else. The fact is, if we were getting our budgets done and done on time, we wouldn't have to be talking about CRs that seem to happen far more often than we should. So I very much appreciate all your comments and understand what you're saying for sure. Because the truth is, a veteran serves this country and they serve it and we make promises. And CRs don't live up to those promises, quite honestly. Any one of you can answer this question. The testimony that you three brought forward raises concerns about community care spending, especially as it compared to spending for direct care. Given the memberships of your organizations and the impacts that their military services had on their abilities physically and mentally, what should we keep in mind as we engage in this conversation about community care versus direct care?
I'll just say, Chairman, VA has always had community care. That's nothing new. We need to continue to realize that direct care, to maintain VA's, to be able to be a provider of care, we need to ensure that acute care is primary or direct care is primary, and that only when VA cannot provide the care in the community should community care be provided outside of the VA.
Okay, appreciate that.
Mr. Chairman,
Yeah, go ahead.
I'll just add really quickly, our veterans consistently tell us that they prefer VA health care and that community care can supplement when needed. So we hope and we ask that VA continue to focus even more on improving their direct care primarily.
Thank you. Okay.
Yes, thank you, Senator. One of our concerns always is VA really managing that veteran? Once they go out in town, they do community care. Is all that information, medications, treatment, being put back in the record, and is the VA successfully managing it? Because if they're not, then we have concerns of polypharmacy. Are veterans being over-medicated? Are the medications being interactive negatively? Is anybody really looking at the negative impacts that this has on their long-term care?
Appreciate it. Appreciate all three of you. Look, we all know the importance of VA staffing, especially VHA staffing. It's all important, though, but truthfully, when it comes to healthcare, those healthcare workers are very important. Benefits are important, too. But I want to focus on the VHA staff. The VA has hired a bunch of folks. There's no doubt about that. It's been pretty well documented. It's also documented pretty well that they're stopping for a second, they're taking a breath, they're going to analyze what they got. I don't necessarily think that's a bad thing, but what I do think is a bad thing is after that analysis is done, they either have to not hire or hire, depending on what that analysis is. Talk about shortcomings of reduced staff and understaffing of VHA and what that does to the VA, especially when we consider we're having a record enrollments right now.
I'll just start with record enrollment. As you said, we want to make sure that we're not seeing increases in wait times either. We want to be able to serve the veterans that we're estimating are going to be coming in the next fiscal year. And VA has roughly 75,000 vacancies still. Our budget recommendations are to try to reach at least a quarter of that. So we hope that VA will continue to rigorously hire.
So right now, your predictions, before I get to you, Roscoe, your predictions right now is that the VA is 75,000 short on healthcare workers?
Yes.
Okay. Go ahead, Roscoe.
VA's first quarter staffing report shows that there's 66,000 vacancies in VHA. For us, we go out and conduct site visits at VA medical centers, SCID centers, and the impact we're seeing is that there are nursing shortages in the SCID program, and they're not able to fill those vacancies. So that means that the current nursing staffs have to take on more responsibilities and duties, burnout, and physician burnouts. And so, you know, and it will only get worse with increasing enrollment as more veterans enroll in the system. Unless we're hiring more people, then the shortages will, and the staffing will tend to burn out. And, you know, working in a unit like spinal cord is not the same as working in an acute care setting.
Amen.
Obviously, when we don't have enough staff, veterans are not going to have the timely access that they need. But then, if you think about it, we're actually now feeding into community care. So the fewer appointments and physicians and nurses that are available, the more we're going to be sending into community care. So then that cost is going to continue to rise. And so then we're going to have less money to spend on direct care, and then we're going to have less people. We're going to feed into this entire system if we're not appropriately staffing healthcare now to make sure they're getting what they need up front when veterans come in for assistance.
Appreciate that. Senator Tillis?
Thank you, Mr. Chair. Thank you all for being here. I've tried to reconcile the comments from Secretary McDonough, which was to, through attrition, manage down 10,000 positions. Does that mean that that number goes from 75,000 to 85,000 in your view?
Honestly, I'm not sure how attrition is going to affect vacancies. I think it's important that attrition is stable.
Yeah.
I think that's a very good thing, and we're happy to hear that.
But I guess I understand that your assessment that there are some 75,000 more positions that need to be filled. Do you believe that that's that is the view and a priority of the VA?
I mean, from anecdotal evidence, we've heard that there's been a pause. So we hope that that really is just to regroup, and we're strongly urging VA to continue hiring and to fill those vacancies.
Here's what I talked with Secretary McDonough, and incidentally, I'm very positive about Secretary McDonough. He's very prepared. I think he's doing a good job. Everybody can improve. I'm sure y'all could say that about your own organizations, but I feel like we're not really addressing the elephant in the room, and that is we are going to get more enrollments. I was going to talk to you all about maybe the increase in disability claims as a result of the PACT Act. I'm kind of interested. It seems like they're triaging the claims pretty quickly. I'm kind of interested in the quality of those exams on the back end and the timeliness. Maybe I can get to that, but I want to get to a macro thing here. And maybe I could be disproven, and maybe I should have thought twice about voting against the PACT Act that had TEAM Act in there, Camp Lejeune toxics. I know that y'all know my office was carrying that through. But I worried about making sure that we got all this stuff squared. And I worry about whether or not we have the funding tail, the staffing tail. You know, at what point do these bills come due? At what point are we potentially going to run into a cliff in the VA for all the commitments we've made versus the positions we can hire and the money we can appropriate? We've got to really step back and make sure. See, in the same way that we're running into a fiscal cliff with Social Security that's probably going to hit somewhere in the next 6 or 8 years. That's when you don't have the money and you start cutting and breaking the promises you've made. So how would y'all suggest we kind of get a big picture view of, I feel like we're kind of talking past each other when I hear we're managing down 10,000 fewer positions. We need 75,000 more positions. We need less community care, but we're not producing, we don't want to put an emphasis on community care, but we're not producing enough indigenous capacity to handle the veterans, and the population's growing. So am I just being overly cynical, or do I feel like Cool Hand Luke, what we have here is a failure to communicate?
Actually, I think all three of us would agree.
Okay.
When we went to the budget briefings and we discussed all of this internally, we're still trying to wrap our head around some of these concepts as well. We're going to lose 10,000 physicians positions due to attrition, but yet we still need 75,000 more. To your point, it doesn't make sense. So our concern, I think, will always be making sure there is enough staffing so veterans have the high-quality VA healthcare when they need it, so we're not over-reliant on community care.
Yep.
And if I may address the PACT Act real quick, just because I was very involved in that and I do a lot of the claims and benefits for this team, we've been pleasantly surprised. Over 956,000, I think, roughly is how many claims have been actually granted. The 1.9 million PACT Act or 1.2 million PACT Act claims that have been filed. So they've actually done a great job in processing the claims. They really have. As far as examinations, I'm always willing to bend somebody's ear for a few hours to talk about VA exams. I won't do that right now. But I think we've seen some improvement in that area. But overall, I think they've done a great job on the PACT Act. Now, right now, as I noted, Senator, 32% of the claims that are pending are backlogged. We knew there was going to be a peak of claims and a backlog claims because of the sheer volume coming through. Overall, I think VA has done a great job with the PACT Act. Obviously, there's more things that they could improve on, they could do better, and we can discuss that later, I can, with your team. But I really think overall they've done much better than most of us were expecting from.
And I'm glad to hear that, because in spite of the fact I voted against it, I'm rooting for it. A lot of the policy in there, but I still worry about this cliff out there, because I stipulate what you all say is being accurate, needs that are unmet. I just don't see how those all square, and I just don't know over what period of time. And Mr. Chair, the only other thing that I hear almost $1 billion funding request for the electronic health record. Is that what I heard? There's got to be more if they decide not to step back from it, which I hope they don't do. But there's just so much stuff out there. And it would be nice over the course of this Congress if we could get it written down or just soothe my worries, out-year worries. We could have a change of administration next year. We could have a change of VA secretaries. We could, a lot of stuff needs to be documented, finished to start. How do we make sure that we're not going to run over a cliff here with all these deficiencies, either in funding and manpower? That's what I'm mainly worried about, and mainly worried about it for the sake of the veterans. Thank you all. I won't.
Let me just, Mr. Tillis, let me
yes,
say,
sir, Roscoe.
To your question, we're at that tipping point, and so the Secretary pretty much is telling us that, because he said they have to make difficult decisions, and they made those difficult decisions. And so how you turn things around, that's the question. Because at some point, if community care continues to rise over direct care, if staffing, they're not filling all of the vacancies that they need to fill, people continue to work longer hours and get burned out, then that has a very negative impact on the quality of care VA provides.
I'll just add one last thing. A lot of the budget recommendations that we're making is to make VA more efficient, and that's going to be cost saving over time. Thank you.
So that's all right.
I still can't think of that word when people revolt and take your job. Oh, there wasn't one of those? Mr. Chairman, thank you. I think many of the points on questions I would have raised with you and asked for your views and your points have been asked, I'm told, because a lot of my questions always relate to community care, and that has been addressed by my colleagues. A couple of things I would ask you, though. The PACT Act directed that the VA hold quarterly engagements with VSOs to help evaluate presumptions of service connection. From these engagements, I guess, tell me about the engagements. Are they mattering? But importantly, do you feel the VA's resourcing, the vet home, the Office of Research and Development, and the broader execution of the presumptive decision process, are those things adequate and focused on delivering the promises of the PACT Act?
Thank you, Senator. They do have quarterly meetings that we've been invited to, off-sites about PACT Act implementation. However, specifically to diseases and what they're looking at and with the home, I don't believe any of those have happened. If they haven't invited DAV, PVA, or VFW. Not to say that they haven't, but we've been asking those questions about when are the presumptives being done. They are informing us they are looking at different categories of diseases, and I believe the K2 study will be out in June. They're looking at a few other diseases, but overall, we're not aware of that. Those quarterly meetings have actually started. They haven't with the VSOs.
That's useful information, and assuming that you want those meetings to take place, I would guess that Senator Tester and I would join each other in insisting, encouraging that the department do what the law requires them to do. Let me talk a moment about the independent budget. PACT Act implementation has led to a large uptick in disability claims filed and processed. Can you speak to what your service officers are seeing with access to disability claims and the quality of these exams during this process? Are your service officers and veterans in your organization seeing any decline in the quality of the outcomes of adjudicated claims? And do you believe that processors are receiving the proper training to adjudicate both PACT Act-related claims, but also specialty claims?
From the perspective of the VFW service officers, we have a wide network of service officers throughout the country, and they're seeing some positive outcomes with PACT Act claims. For the veterans that we represent, they are being processed in a timely manner. Of course, it could be quicker, but we are seeing positive outcomes. There's always more to be worked on, but from this point of view, for the moment, those PACT Act claims are going through. Now, we are recommending through our budget recommendations that VA hire more claims processors, raters, and that they constantly have the oversight over C&P exams so that veterans can, if need be, reschedule depending on their daily lives, that kind of thing. So we are continuing to monitor this, but we are optimistic that this has been a good outcome with the PACT Act, and the VA is taking this seriously, and they are processing more claims than ever before in history.
Christina, do you see any reduction in the quality of the examination of the determination?
So we know that the approvals for PACT Act claims have gone up percentage-wise, and that was sort of a big concern of ours before the PACT Act. So that is a positive change. There are always going to be some cases where we're not satisfied or the veteran is not satisfied, and we really think oversight and quality assurance is really key to monitoring that process.
Thank you for both of your answers. This is a question that I was going to ask the Secretary, but I'd like for you to express your views on this topic. State veterans' homes play an important role in caring for aging veterans and are critical partners of the VA. I'm concerned that the VA is only requesting $141 million for grants for construction of state home facilities, which represents a 14% decrease from FY24. The current priority list is over 100 projects with a total VA cost share of nearly $1.8 billion. That doesn't come close to meeting the need. And I would like your response to, since I can't ask the Secretary the justification, maybe you can help me make the case for either this is appropriate or insufficient.
I mean, just looking at the numbers, $141 million is what VA is requesting, and collectively, the IBVSOs are requesting or suggesting $600 million for state veteran home construction grants. So we really see that there's a strong need. We have an aging veteran population, and so we really need to be considerate of all aspects of health care for veterans.
And if I may, there's a local cemetery, or excuse me, state home. Been a long day. Not too far from where I live, I'm very active in a DAV chapter in Arlington, Fairfax, Northern Virginia. There was a state veteran home that was authorized and paid for grants by VA and by the state. It's been built and empty for 2 years. We try to get answers so that our aging members in that area can have access. We're being told by the state nursing, the state of Virginia, that the problem is actually a federal VA problem because VA needs to make decisions. VA is saying, no, we gave you the grants, you have everything you need. So an example of a problem within the system for grants and getting it done, there's a nursing home in Northern Virginia that's been complete for 2 years when nobody's occupied it.
Mr. Learman, you used your time just like I did use mine, just to get somebody else to highlight a problem in hopes that they fix it. And we'll work with you on this as well to see if we can't get VA attention. Mr. Chairman, that concludes my questions.
So. It's not being used. Is this a state veterans home or is this a federal? It's a VA.
That's the problem. It's a state veterans home, but we're being told it's controlled by the federal, and that's why it's a very confusing problem.
Look, I mean, you ping pong things back and forth, but the truth is there's an expenditure of taxpayer dollars here that was a total waste of money unless they get that thing opened up and provide the services. I'm going to tell you that I will get a hold of Kane and the other fellow's name. What's his name? I can't remember it really quick.
You're not asking me, you're asking your staff.
No, it's it. At any rate, I say that in jest, but we'll get a hold of the two senators from Virginia.
Oh, Virginia, I do know those guys.
Do you?
Yeah.
Well, we'll put them to work. Because the truth of the matter is this is crazy, and it's just flat stupid. So we will do that. So they might be calling you. So it's good. I want to thank you guys for being here, gals, guys, everybody, for the independent budget. Of course, thank the secretary. Both these panels are really critically important as we work through the 2025 appropriations process. This record will be kept open for a week. Any questions, I would ask that you respond to them as quickly as you can. This hearing is now adjourned.